Our patient is a 30-year-old male who fractured part of his spine after falling off a ladder 8 days ago. He had surgery to stabilize the fracture, internal fixation of the spinal column, and decompression using a right iliac bone graft. He is currently wearing a TLSO that is to be worn at all times unless in bed. He is to log roll only unless wearing his TLSO. He has been diagnosed with an incomplete T8 spinal cord injury, classified as a B on the Asia Impairment Scale. He has no significant past medical history or complications. He's currently experiencing significant spasticity and pain in his lower extremities, and he's been placed on baclofen to help control his spasticity and Flomax to assist in urination. Our patient lives with his wife and infant daughter in a split-level house with 6 steps to enter and 6 more to get to the main level. He is a self-employed certified public accountant.
A spinal cord injury is damage to the spinal cord that affects sensory function, motor control, and reflexes in specific areas related to the level of the spinal injury. The higher on the spine the injury occurs, the more structures of the body are affected. Spinal cord injuries occur more frequently in men than in women, primarily in men between ages of 16 and 30 due to more risky behaviors. 72 hours after the injury, a series of tests are performed to determine the level and severity, and the patient is graded accordingly based on how intact the patient's sensory and motor systems are. Complete spinal cord severances result in total loss of sensory and motor function below the level of injury and earns an A on the Asia Impairment Scale. Our patient was graded B, which means that he has some sensation but no motor control below the level of his injury due to part of the spinal cord remaining intact.
The muscles innervated by T8 include the intercostals, sacrospinalis, semispinalis, and the abdominals. Therefore, the patient may experience some pulmonary dysfunction, including decreased respiration capacity and compromised endurance. This may also lead to paradoxical breathing patterns that are inefficient and have a high energy cost, which can cause fatigue. Due to the incompleteness of the spinal cord injury, our patient may have some intact sensation below the level of lesion. We recommend that he be tested for sacral sparing in order to determine future independence with toileting.
Our patient displays complete paralysis of lower trunk and legs due to damage at T8 spinal cord level, significant spasticity of his lower extremity that implies upper motor neuron damage, and significant central pain in his lower extremities.
Interventions should include deep breathing techniques, a turning schedule, bed mobility training, specific treatments to decrease spasticity, pain management, and strengthening exercises for the upper extremity. Breath stacking and incentive spirometry training will help improve lung capacity and strengthen the involved muscles. The patient should take small consecutive inspiratory breaths until full lung capacity is achieved. The patient should then exhale slowly until the lungs are empty. This technique will increase intercostal endurance and total lung capacity.
The importance of a turning schedule and skin checks to prevent skin breakdown should be discussed with the patient as soon as possible. Skin breakdown can lead to pressure ulcers and potential complications due to infection of developing wounds. Due to the healing fracture and acute phase of rehabilitation, our patient is to log roll only for safety during bed mobility training. The patient should accomplish as much of this on his own as possible. The therapist or PTA will still need to facilitate by moving the lower extremities carefully into hook-lying position at this time. The patient should be instructed to cross their arms over their chest and keep their spine as straight as possible while the clinician guides the rolling movement. Since our patient is still in the acute phase, he will need help facilitating this movement.
Treatment for spasticity includes prolonged stretching of the lower extremities, massage, relaxation techniques like guided meditation and mindfulness exercises, and slow vestibular stimulation. These may all help decrease the spasticity in our patient's lower extremities. This patient is already on baclofen to reduce spasticity. However, his level of spasticity is still significant. Seen here are prolonged stretching of the lower extremities, followed by slow vestibular stimulation. Although TENS has been shown to manage pain, it should not be used in this case to avoid triggering autonomic dysreflexia. Although this disorder is less common in patients with incomplete spinal cord injury, it may still appear 3 to 6 months post-injury. Using e-stim below the level of injury may increase spasticity in the area if this condition is present.
Massage can be used to help with lower extremity pain, and mental imagery accompanied by cardio biofeedback can assist with relaxation. This patient should consult his doctor about medication to help control his pain levels. This patient needs to strengthen his elbow and shoulder extensors to facilitate repositioning, as well as bed and wheelchair mobility. Exercises for scapular retractors will help with postural control. The exercises seen here include supine tricep extension with red T-band, aka skull crushers, seated overhead tricep press, red T-band pull-aparts starting in scaption, and supine shoulder flexion. After patient's fracture stabilization has healed and he is cleared for movement without the TLSO, we want to progress his exercises to focus on strengthening his upper trunk extensors and increase his remaining thoracic, cervical, and shoulder range of motion.
This patient's prognosis is good. He's young with a low level of incomplete spinal cord injury. Due to a high level of preserved upper extremity function, this patient will eventually be able to independently manage many aspects of his life, including activities of daily living, toileting, wheelchair mobility both in the home and the community, and transfers. He will also still be able to work and drive with the use of hand controls. However, any decrease in respiratory capacity, endurance, or an increase in severe spasticity may limit his independence. He will also require assistance with many daily domestic chores, like heavy cleaning, reaching desired objects from high places, and home maintenance.
Since this patient is paralyzed from the level of lesion and downward, he's going to need a fitted wheelchair. It will need to be lightweight and relatively easy to transport so he can remain involved in his community. Along with the wheelchair, he should also have a pressure relief pad since he's going to be seated most of the time. He'll need a bathing chair so that he can independently transfer into and out of the bath or shower. If he wants to continue to drive, he'll need adaptive hand controls for his car. He'll need a ramp installed so that he can get in and out of his own house, and he'll probably need an electric stair lift in his home to get him to the main level of the house as well.
This patient's biggest challenge to his mobility is stairs. Other obstacles include transportation of his wheelchair when he's not in it, objects that are out of reach, hallways that are too narrow to accommodate wheelchairs, and bathrooms or building entrances that are not wheelchair accessible. The physical therapist or case manager should do a home evaluation to determine whether or not our patient's home environment can be adapted to his needs.
But it didn't do anything.